Going to open a public hearing on Senate Bill 822. And while Mr. Dietz is coming up, I'd like to ask Jesse O'Brien and Numi Griffith to come to the podium. Thank you. And we'll be followed by Angela Donnelly. And then remotely, Dr. Todd and Dr. Murphy. Thank you.
Ready?
Yes, thanks, son.
Chair, Vice Chair, members of the committee, members of the public, Senate Bill 822 directs the Department of Consumer and Business Services, you'll hear the acronym DCBS today, to adopt new rules to evaluate the adequacy of provider networks of health insurance carriers that offer individual or group benefit plans. It specifies that the adequacy review should include the ratio of providers to enrollees, the geographic distribution of providers, and wait times for care. It directs the agency to adopt standards to evaluate networks for covered services, including services for mental health and substance use disorder. And it specifies that the agency is directed to adopt standards to evaluate whether networks provide appropriate culturally competent care to all enrollees.
Thank you so much. Mr. Bragg.
Chair Patterson, Vice Chair Hayden, members of the committee. For the record, my name is Jesse O'Brien. I'm the policy manager with the Division of Financial Regulation at DCBS. And since I believe this is our first time before the committee this session, I should maybe also say for the record, in case Division of Financial Regulation seems like an odd entity to be in front of you all, we are the state regulator of all lines of insurance, which includes commercial health insurance, which is our intersection with this committee and what we're here to talk about today. Today we're here to discuss Senate Bill 822 and its importance in addressing access to health care for Oregonians covered by commercial health benefit plans. So what is network adequacy? So it refers to the ability of a health benefit plan to provide enrollees with timely access to a sufficient number of in-network providers to access all covered services without unreasonable delays. And network adequacy might not seem like the most inspiring term. You would want to aspire for something beyond adequacy, but that is the term for our oversight of health insurance networks under a health benefit plan. We do have an Oregon law cited here that's been in place since the 2015 legislative session that establishes a baseline network adequacy standard. However, there have been difficulties with that law that we'll be getting into in a few minutes. Without adequate networks, this may go without saying to this audience, but consumers may face long wait times for covered services, excessive travel burdens, or financial hardships if they're unable to get care covered. So we wanted to give a little bit of background to give you the sense of the scope of what we're talking about with this legislation. This pie chart, a couple of pie charts here, covers health insurance enrollment across different lines of business in Oregon. And this blue pie slice here represents the commercial market, which is what this would cover. So that's large and small employer plans that are so-called fully insured plans, that is plans that are purchased through a health insurance company, as well as individual plans which are purchased by individuals on their own, either directly from a company or through the health insurance exchange or marketplace. And together, that pie slice represents somewhere between 20 and 25% of the insured population in Oregon, and the rest is these various other programs listed here. One thing that makes this especially confusing is the pie slice labeled ERISA self-insured. Those are typically large employers that do not purchase coverage through a health insurer, but instead cover the cost of their employees' health benefit directly. But confusingly, they sometimes use an insurer as a claims administrator, so that can create some confusion there. The jurisdiction of DCBS as the insurance regulator in health insurance is really only within the smaller blue segment here, and then our current network adequacy law only applies to small group and individual plans. So it only applies to that smaller chunk of the larger blue pie slice here.
Mr. O'Brien, before you go on, what is ATM thereafter?
Oh, that's a great question, Chair Patterson. That is referring to
Chair Patterson, for the record, name me Rayful Griffith, Senior Policy Advisor, DCPS DFR. So ATM is a term that refers to associations, trusts, and MUAs, which is an acronym within an acronym that stands for Multiple Employer Welfare Arrangements. So those are a number of other categories of entities that offer large group plans that are not necessarily direct employers in the same way.
Thanks for the lifeline. Yes, those are typically ways of grouping employers together to offer insurance coverage. Okay, so Senate Bill 822 expands upon Oregon's existing network adequacy law in several important ways. First, and perhaps most significant in a sense, is expanding the law to cover large group health benefit plans. So again, those are the fully insured large employer plans that are currently exempt from the law. It also will establish quantitative network adequacy standards. Currently, the standard in our law is quite vague. There is an annual reporting requirement where insurers report against a nationally recognized network adequacy standard, but there isn't an ongoing compliance standard. And the standard is effectively that carriers must have an adequate network. And that is very difficult for us to enforce and to turn into a concrete requirement. And then there are provisions related to enhancing culturally and linguistically appropriate care within a health benefit plan, as well as integrating telemedicine into network adequacy standards. And just speaking briefly to expanding protections to large group plans, as mentioned, they are not subject to network adequacy requirements under current Oregon law, with one narrow exception, which relates to the provider directory posting requirements, so network transparency, but they are not subject to the reporting requirements or the general standard that a network must be adequate under state law. However, we do receive complaints about network access under those plans that are not currently actionable, and there's really no clear difference between the plans as far as the volume of complaints or number of issues that we hear. So we think it is important to expand oversight in this area. And Senate Bill 822 extends the critical network access protection to that market.
Can I ask another question before you
please.
go on? And we'll see if there are other questions. What is the actionable action that is in place for the smaller groups? Sorry.
So Senator Patterson, Chair Patterson, that is, ultimately, there are a number of things we might do when we receive a complaint about a possible violation of the insurance code. Ideally, we can resolve the issue by working with, on a one-on-one basis with the consumer and the insurance company to resolve their situation on a voluntary basis. If a situation gets sufficiently escalated or the company refuses to provide what we believe the law requires, it can be taken to an administrative proceeding, and the company could be subject to civil penalties. That is not something that has happened to date with our network adequacy law, but I would also note that our network adequacy law is quite vague in its current form. But it is fairly common for other types of violations of the insurance code to lead to that type of action.
Thank you. And I know you had a question.
Yes, thank you, Chair Patterson. So back on slide 3, when you're looking at the health insurance enrollment in Oregon, we're looking at the small group versus a large group, so kind of a slice of that. My question is, there seems to be one category completely missing here and one category that's lumped in. Fee-for-service is part of the 1.423022 million people that have Medicaid through the state system, but it's around 100,000. I don't know exactly what the number is today. That there is no network adequacy. So we have the state saying, hey, we're going to take care of health care for these 100,000 people, give or take, but they don't require themselves to provide any network adequacy. So my first question is, will they be included? Because I've argued for a decade here that they should have network adequacy for that population. And I don't see at all on here our correctional facilities that do have a network or do have health services within our correctional facilities. Are they included, and why don't we see them on the chart here? And I know that, you know, you're probably going to say, well, it's a different program, but Medicare's on here, federal programs are on here. What about our correctional institutions? And will they be wrapped in here to have network adequacy, which I believe is significantly lacking, in my opinion, in both of those settings?
Chair Patterson, Vice Chair Hayden, we could include the correctional programs on a slide like this in the future. I'm not sure what the numbers look like, but as to the scope of the legislation, it really applies only to the commercial market, and that's not a value judgment of whether it's more or less important than other parts of the market. It's just that's DCBS's scope of jurisdiction. I know that there are network adequacy requirements for CCOs in the Oregon Health Plan program, that we have borrowed some things for our own thinking about network adequacy, but I can't speak to open card Medicaid or corrections or anything else because it is beyond our authority.
Just one brief comment. Thank you, Chair Patterson. So, you know, someday I would love to see that we as a state, and I understand your DCBS, but we as a state kind of lead by example rather than, you know, do as I say rather than do as I do. And what I mean by that, we as a state are responsible for the fee-for-service members, that 100,000 members, and we work with our tribal partners to help them to the extent, but that's a small portion of that, and our correctional facilities, but we still don't require of ourselves to make sure that those folks have a network adequacy. So just my kind of pet peeve, I guess, I've had for a decade here.
No, thank you for raising that issue.
So moving on, I will pass it to my colleague, Numi Rayfield-Griffith.
Thanks, Jesse. For the record, again, Numi Rayfield-Griffith, Senior Policy Advisor, DCBS DFR. So I'm going to do my best to guide you through the weeds of what Jesse just went over at a fairly high level. So I think the biggest part of this bill is establishing quantifiable standards. Right now, as Jesse kind of talked about a little bit, carriers are required to file an annual report with us on network adequacy that basically says, hey, we have an adequate network. We have enough providers to meet the needs of our members. But there isn't really a clear compliance standard in the law for right now what that means. It's just effectively that the network needs to be adequate, period. So that's not really something we can test against. We can get the report, we can say, well, okay, we got the report, but that's kind of the end of the analysis. So Senate Bill 822 would direct the department to develop clear, measurable benchmarks for assessing network adequacy. The benchmarks that we are going to establish include, but are not limited to, geographic access. So that's distance. How far away is the provider? Provider to patient ratios. There must be a sufficient number of providers in an area to meet the needs of the population in that area. And appointment wait times, which is what is the acceptable amount of time you have to wait for an appointment before you actually get that. Our intent in this is to have these standards to be largely consistent with the current federal standards for qualified health plans, which are offered on the health insurance marketplace. Those standards were, I think they're about 2 years old now, is that right? Have been in place for a couple of years, with some allowance for flexibility to adjust as needed for sort of Oregon-specific factors, which is, you know, we have unique market dynamics or unique requirements under the law, such as, you know, requirements to cover specific services that might not be required to be covered under the federal law right now. Next slide. So that was the sort of quantifiable side of things. And setting up those standards that we'd actually be able to test against. Other things that we've put into the bill is relating to culturally appropriate care. It's really important to note that network adequacy is a two-way street. and health insurance carriers cannot be expected to address access issues, or in other areas that are primarily due to shortages of providers or a lack of providers with specific language, competency, or expertise working with a specific population group. If the provider doesn't exist that meets those needs, then the insurer is not required to conjure that provider out of thin air in order to meet network adequacy. However, it is our expectation that carriers would work with their networks to seek to expand access and address access concerns for these issues related to culturally appropriate and language access issues. We think that implementing these provisions is going to be an iterative process over many years, and we would not expect the passage of the law to immediately address all of these issues, but we're really ready to work collaboratively with carriers and providers and advocates to make progress in these areas. Next slide. So telemedicine. Obviously, of course, the use of telemedicine has grown in recent years, particularly in the behavioral health zone, where in a lot of cases, almost all of the services are being provided through telemedicine. So right now, under the current law, telemedicine is prohibited as a means of meeting network adequacy. We don't think that provides sufficient flexibility in the current environment. So Senate Bill 822 would enable the use of telemedicine to meet network adequacy standards, but we would have discretion to define by rule the extent to which that is allowed. I want to emphasize that this flexibility is especially valuable for rural areas where in-person provider access may be limited and thereby reduce the patient burden. So if the nearest doctor is 100 miles away, that you're not dealing with that problem, that the carrier can, in some cases, use telemedicine in order to have an adequate network. Even though there is flexibility, that it doesn't say that we have to do this way, this is giving us flexibility. This is something that we really intend to do. We recognize that telemedicine is an important part of how care is provided right now, and so our intent is to have flexibility in allowing telemedicine be used to meet our network adequacy standards moving forward. Other provisions in the bill, there's language related to reproductive health access. This is adding reproductive health services to the services that must be accessible. So that's the categories of services which are subject to the network adequacy requirement. To clarify, this doesn't mean we're adding any additional reproductive health services to the network adequacy law that are not already required under Oregon law. It's just a clarification that this is an area of focus for us in terms of thinking about network adequacy, given the widespread interest in ensuring access to these services. And finally, the fun technical stuff, we're removing outdated provisions from the current law. So the law is currently written, it provides insurers the option to use a factor-based approach to demonstrate network adequacy compliance. To our knowledge, the carriers are not using a factor-based approach, and it's not really aligned with the way that we want to do this going forward. We want to move towards this more quantifiable method. So Senate Bill 822 would repeal those provisions. And I think that closes this out. So these measures would allow us to address critical challenges with patients affecting timely access and having good quality of care, and we really appreciate your support on this effort. Thanks for your time. We'd be happy to answer any further questions.
Thank you both very much. Are there any further questions before we call up our other speakers? Thank you very much. I believe Angela Donnelly is here in person. Oh, there you are, Angela. And then Dr. Mesa Todd and Dr. Claire Murphy following online. Thank you. Good afternoon.
Good afternoon, Chair Patterson, Vice Chair Hayden, members of the committee. My name is Angela Donnelly. I'm here on behalf of Oregon Consumer Justice. Oregon Consumer Justice works collaboratively across policy and advocacy, community engagement, and the law to realize a more just and equitable Oregon where people come first. I appreciate the opportunity to provide testimony in support of SB 822. We believe that consumers deserve access to quality, culturally appropriate healthcare that's readily available within their communities. This bill is a step in the right direction. With Oregon having an estimated 97% of consumers with health coverage, it's imperative that our system grows to meet the need. Statewide, consumers face barriers to accessing adequate health care. Rural communities have limited access to providers, if any, and often have to travel long distances to receive needed services, while those from our immigrant communities and communities of color must contend with cultural and language barriers when seeking care. SB 822 will begin to fill the system gaps by requiring access to culturally competent healthcare providers and establishing clear standards for in-network providers. Thank you so much, and we urge your support on SB 822.
Thank you very much. Thank you. Dr. Todd, welcome.
Oh, okay. Oh, goodness. Pardon me. My
No problem.
phone is,
There you
I'm
are.
so sorry. Am I showing now?
Yes. Uh-huh.
Okay, great. I don't know what happened. My phone decided to connect and without my permission.
No problem. Welcome. If you could introduce yourself for the record.
Yes. My name is Melissa Todd, and I am a psychologist in Eugene, Oregon, and I'm here on behalf of both myself and the Oregon Independent Mental Health Professionals. We are a legislative advocacy committee that is supported by the Western Oregon Mental Health Alliance, and we're here to support SB 822. We stand for mental health parity enforcement and increasing access to mental health care in Oregon. And this is something that we've been doing for many, many years. And network adequacy is something that we really care a lot about because it has historically been used by some insurers to limit access to behavioral health care. And so we absolutely support efforts by the state to expand on, network adequacy laws, applying them now to more health plans. And we also support efforts to quantify network adequacy standards to make them easier to measure and to determine when an insurer is in compliance or out of compliance. Essentially, we want to be able to be in network with health insurance because we believe that people have a right to access in-network care. And so we want to support anything that will help move that forward. As a psychologist who is fully practicing, so the work that I do for the Legislative Advocacy Committee is something that I kind of do on the side. I'm an independent practitioner, and this topic is near and dear to me because I actually left an insurance network in 2017, and I was extremely conflicted about doing that. It really went against my value of wanting to give more people access to care, and it wasn't a decision that I took lightly. And so ever since that happened, I have made it kind of my personal mission to do everything that I can to influence the system so that it is more tenable for solo practitioners like myself to be in network with as many health insurance companies as possible. And so, ultimately, the way that I look at this is that, this shines a light on insurance companies and which ones are doing their job to create adequate networks of behavioral health providers. And I think it would make it more difficult for the ones who aren't doing that. And, part of what needs to happen for more behavioral health providers to be in network is to restore trust and to kind of repair some of the damage that was done in the past. And I view this as a step in the right direction because if insurance companies have to maintain adequate networks of behavioral health providers, then they're going to really have to look at their policies and they're going to have to look at how they can gain our trust again. Consumers most consumers do not have a choice in what health insurance they have. Most of them get health insurance through their employers, and they're playing by the rules. And so they should be able to access the in-network behavioral health care that they deserve. Thank you.
Thank you so much, Dr. Todd, for your testimony and for your work. Thank you. Dr. Murphy, welcome.
Hi, I'm Dr. Murphy. I'm a pathologist in Eugene, Oregon, so I guess Eugene is representing today. I work at an independent practice that's contracted by the hospital and clinics nearby. I'm in charge of the transfusion services, and I do hematopathology as well as general pathology, which includes reading biopsies that you would get from anywhere in the body. And then the laboratory, we have medical directorships, so any blood testing that you get, we ensure the quality. And that's what a pathologist does on a daily basis. We don't necessarily see patients, but on a slide. And so we want to point out that we would like to support this bill, 822, in terms of network adequacy, but also to work on maybe amending the language a little bit to include hospital-based services like anesthesiology, emergency medicine, and pathology, because even if it's in a clinic or you come to the hospital, laboratory tests are ordered, maybe a biopsy is performed, and these not patient-facing specialties may not be in network. We try very hard to be in network with all the plans that the hospital is, but it would be nice to put some more teeth into this to include all of these specialties that you may see in the hospital that are not just the primary care provider. So essentially, speaking in support, echo all of everything that's been said so far. But I know the Oregon Medical Association is working with another part of, something I don't know. I'm a pathologist, not necessarily always in the weeds of legislative details, but I know that they're working on an amendment to include some of the hospital-based services.
Thank you very much for your testimony. I know we do have someone from the Oregon Medical Association here to testify today too as well. So thank you for taking the time to testify on this bill. Appreciate it.
Yeah.
We have two more people signed up to testify here in person. I'd like to call Marianne Cooper, followed by Courtney Dresser. And then I'm going to call and see if anyone else is registered, because I see some puzzled looks, so I'm assuming Rick is also signed up to register. Would you like to come and join us too? Thank you. Go ahead.
Chair Patterson and members of the committee, thank you for the opportunity to testify today. My name is Marianne Cooper, and I'm the Director of Government Relations for Regions Blue Cross Blue Shield of Oregon. We are a tax-paying nonprofit. We serve nearly 1 million Oregonians. And network adequacy is obviously a really important function and tenet of the work that we do. We have been in ongoing conversations with DFR about Senate Bill 822, as you heard, which would significantly change Oregon's network adequacy laws. We agree with DFR that the network adequacy statutes are outdated and need to be updated, and we appreciate DFR's outreach to carriers about the legislation in advance of this session. While most of the changes made in the statute are workable and we understand, we remain uncomfortable with the number of standards that are left to DFR to define in rulemaking. The vast discretion left to the agency creates considerable uncertainty for carriers. In 2023, the Centers for Medicare and Medicaid Services adopted extensive new network adequacy requirements for the individual market with the goal of improving access to care and health equity. DFR's stated goal with this amendment is to align with and codify these new federal standards and extend their reach into the small group and large group markets. We are requesting that the bill be amended to empower DFR to adopt rules that are no more stringent than the federal rules in place on December 31st, 2024 regarding geographic access to care and wait times. We request removal of the section providing provider to patient ratios, as that is outside the scope of the federal rulemaking and outside the scope of DFR's expertise. We are also concerned that as the state adopts more stringent network adequacy requirements, we will see continued consolidation of hospitals and providers, and that we might see more instances of health systems demanding contract increases beyond what is necessary to sustain their operations because they know that their system is necessary to meet a carrier's network adequacy requirements. As such, we are asking that if a health system is moving out of a carrier's network due to a contract termination where the health system asks for a contract increase in excess of the state's cost growth target without justification, that the DFR be able to waive network adequacy requirements with respect to that carrier and that health system. This will help ensure that the more stringent network adequacy requirements are not used as a lever to demand contract increases simply because of the market share that a provider occupies in a region. So thank you for your consideration, and I'm happy to take any questions that you have.
Thank you. Would you like to go next, Mr. Blackwell?
Sure. Thank you,
I think
Chair
you're on the
Patterson.
same
and-
topic.
Of course. Thank you, Chair Patterson, Vice Chair Hayden. Rick Blackwell with Pacific Source. I admit I didn't sign up till 1:30, so maybe that's part of the issue. We want to express our appreciation for DCBS working with us to try to figure out an acceptable path forward on this bill. We're signed up in opposition, but it's mostly about some of the language of the bill, not necessarily the concept. Again, this was a bill that was passed in 2015, and it's taken some, it's probably time to revisit these standards. I also want to note for the committee that uniquely among all the participants in the healthcare system, we're the only entity that has any legal obligation to contract with anyone else. So, that puts us in a unique position when it comes to trying to construct networks of providers. So we're asking for two possible amendments that would accomplish two things. One is allowing some but not full credit for telemedicine to construct provider networks. I think the main difference between the DCBS approach that's in the bill and the one that we're requesting is that there's a more affirmative requirement to complete that rulemaking. As DCBS said in testimony, the first bill was passed in 2015. It took almost a solid 2 years to finish the rulemaking for this set of standards alone. We just want to make sure it doesn't get lost in the wash when rulemaking begins. More importantly, though, we also believe that standards should be aligned with federal standards in effect as of December 31st, 2024. We operate in 3 states, and so uniformity across our borders is important to reduce administrative burden, but to ensure similar care for all the members that we serve. We believe Oregon should align its network adequacy standards to applicable federal standards. We're mindful that federal standards could change, so we think a static date in statute could help provide more consumer protection in this space. Federal standards that could be applicable across Medicaid, and to your question earlier, Senator Hayden, making sure that fee-for-service, managed Medicaid, and the marketplace all have similar and aligned federal standards could help with uniform access. Managed Medicaid already has some time and distance and wait time standards that are in place for managed Medicaid, and they could be a good example for the department here. That being said, we don't really see a situation where Oregon is really that unique in the West. I love Oregon. I've lived here the longest I've ever lived in a place, but we are a state with urban centers and large rural areas. This is a Western issue, and we're not really convinced yet that DCBS would need to exceed federal standards for network adequacy purposes. Finally, while we're not opposing this provision necessarily, the requirement to construct networks in an appropriate and culturally competent manner could present some implementation challenges in the future. We had a similar requirement that was placed on managed Medicaid for provider directories. We had a minuscule amount of folks actually supply the information to make the provider directories worthwhile. So buy-in and feedback from providers will be crucial to make sure that we can even operationalize that provision. So with that, I'll end my testimony. Thank you.
Thank you very much. Good afternoon.
Good afternoon, Chair Patterson, members of the committee. Courtney Dresser with the Oregon Medical Association. Our association is physicians and physician associates and students of those professions. We are advocates of a robust network adequacy rules and regulations. Network adequacy usually means that patients are better served because they're getting quality health care with reasonable prices and not receiving any out-of-network balance billings. You've heard from the Oregon Pathologist Association about the amendment that we are shopping around. And that is really looking at trying to ensure that hospital-based services like laboratory work anesthesiology, emergency departments are also part of the network adequacy requirements in the sense of what DCBS would be looking at for standards. The reason for this is because we know that these are some of the more expensive pieces of hospital care that many times are out of network, and many times patients are not aware of that. This is very similar language, if not exact language, to rules and regulations in many states, including our neighbors in Washington, California, and other places like Texas and Georgia, Louisiana, Tennessee, and other places. So hopefully our friends at the insurers would like that uniformity. So we are meeting with DCBS soon to have this conversation with them, and we hope to see this amendment come through this bill as it moves forward.
Thank you very much. Are there any questions? Yes.
So just to clarify, Oregon Medical Association is opposed to it currently.
We support the bill. We would like to add some language.
You want it amended?
Yes, we do.
I'm good.
Question? Well, just to double check, has anyone else signed up to register for this? Seeing no hands and no panicked faces at the back of the room. Sorry, thank you. Thank you very much for your testimony. Yes, oh, I'm sorry.
There was some pointing at the front.
Oh, yes, please.
Grab my chair.
Sorry. Good afternoon.
Hello. For the record, Dr. Vern Sable, representing the Oregon Chiropractic Association. I did sign up. I've submitted testimony and some exhibits. We are in support of Senate Bill 822, and I wanted to focus my comments on page 2, lines 11 through 18, which is known as the provider non-discrimination provisions. And relative to that, carriers not being allowed to discriminate against any type of provider, not the least of which is chiropractic physicians, as it relates to participation coverage and reimbursement. Relative to participation, it's not an any willing provider provision, but they must allow all networks must allow some chiropractic physicians and any other healthcare provider on their panel, and it has to be an adequate network where possible. Coverage simply meaning that if it's a covered health benefit, and for example, it's within the scope of the license and practice of a chiropractic physician to provide, and we provide it, they have to reimburse us for it. There's 2017 OAR that clarifies that as well. Probably the area that has the most confusion is relative to not discriminating as far as reimbursement. When in line 17 and 18, the statute states, this is copying from the 2015 the governor inserted into this bill. This subsection does not prevent a carrier from establishing very reimbursement rates based on quality or performance measures. The intent, dating all the way back to the Accountable Care Act, where this language originated from, which was inserted into the CCO bill, and then the first network adequacy bill, House Bill 2468, was you have to pay us all this, pay us all the same for the same service, provided it's within our scope, license, or certification. However, a carrier can vary reimbursement based on quality or performance measures, patient outcomes, the goal of which is simply to improve quality of care for erroneous for patients. That's the whole goal of it. And so we're hoping that moving forward that will be clarified. Again, we appreciate Governor Kotek bringing this forward, and we look forward to helping in any way we can. Thank you.